نبدأ. بسم الله الرحمن الرحيم.
وسهلا.
السلام عليكم ورحمة الله وبركاته. تحية من الجمعية الطبية القطرية، من أطباء اليمن في المهجر، ومن الجمعية اليمنية للمسالك البولية، وكذلك من برنامج زمالة جراحة المناظير في العراق. يسرني في البداية أن أشكر جميع الجمعيات المشاركة، وأشكر جميع المتحدثين اليوم. كما يسرني أيضا أن أشكر جميع الحضور من زملاء المسالك في اليمن وقطر، العراق، فلسطين، وكذلك من الأردن. شكرا للحضور. نتمنى أن يعني أن نحصل على الفائدة المرجوة من هذا الويبينار. والويبينار هذا استمرار لسلسلة من النشاطات العلمية التي بدأتها الجمعية الطبية القطرية بالمشاركة مع الجمعيات المختلفة. كان الويبينار الماضي بمشاركة جمعية المسالك اليمنية والجمعية الطبية القطرية، وأيضا جمعية أطباء اليمن في المهجر. الإضافة الرائعة هذه المرة هي دخول الزملاء من العراق، ووجود برنامج زمالة جراحة المناظير معنا اليوم في هذا النشاط. بداية يسرني أن أدعو الدكتور عبد الله النعيمي، رئيس الجمعية الطبية القطرية، وأيضا مدير برنامج الزمالة وأيضا الريزيدنسي في مؤسسة حمد الطبية. يتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. بسم الله، الحمد لله والصلاة والسلام على رسول الله. في البداية أحييكم جميعا في هذا اللقاء المتجدد. نسأل الله سبحانه وتعالى أن يعلمنا ما ينفعنا وينفعنا بما علمنا، هو ولي ذلك والقادر عليه. أنا لا أريد أن تكون صراحة خطابات، ولكن لا بد من يعني إحقاق الحق وتقدم في هذه الكلمة المختصرة أن أشكر كل من شارك وعاون وساعد على إنجاح هذا العمل. طبعا أخواننا الأطباء اليمنيين في المهجر كانت لهم بصمة في هذا الأمر، كذلك جمعية الأطباء المسالك في اليمن وشاركت في هذا الأمر. اليوم ينضم إلينا الأخوة من العراق. شكرا جزيلا لكم على هذا الدعم والتنسيق. كما وأحب صراحة أن أشكر المحاضرين على مشاركتهم في هذا العمل. أشكر جمعية الأطباء، وأخص بالشكر صراحة اللجنة الإعلامية والأكاديمية على رأس هذا الهرم، أختنا الدكتورة مريم والدكتور خالد الجلهم. إن كان ولا بد من كلمة على عجالة، فصراحة أنوه إلى أمرين. الأمر الأول أن سبحان الله يعني قد يمر الإنسان بأمور سيئة، لكن يبقى المسلم ينظر للجانب الإيجابي لكل أمر سيء. الكورونا أمر لا نتمناه، ولكن وجدنا فيه إيجابيات كثيرة. أحد هذه الإيجابيات هي ما يحدث اليوم. اخترقنا الحدود، وصلنا للقلوب ولأحبائنا في أقطار الوطن العربي من خلال ما استفدنا وتعلمنا من جائحة كورونا بالاستفادة بالمواقع السوشيال ميديا والاجتماعية. فاليوم والحمد لله البادرة مستمرة ومتكررة. أمر آخر وصراحة أوجه لأخوتي المحاضرين، حديث النبي عليه الصلاة والسلام: ينقطع عمل ابن آدم إلا من ثلاث، ومنها عمل ينتفع به. وإن شاء الله هذا العمل هو ما ينتفع به، سواء من إخوتنا المحاضرين للمشاركين من خلال نقل العلم والفائدة، كما قد يكون من المشاركين مما سيتلقونه إلى مرضاهم، ويكون هذا يكتب لهم الأجر. أسأل الله سبحانه وتعالى أن لا يحرمنا أجر هذا العمل، وأن ينفع بنا وينفعنا به إن شاء الله. لا أريد أن أطيل عليكم. وفقكم الله، تمنياتي لكم بالنجاح. أخوكم ومحبكم دكتور عبد الله النعيمي من جمعية الأطباء القطرية. السلام عليكم ورحمة الله.
شكرا جزيلا دكتور عبد الله النعيمي على الكلمة القصيرة والرائعة والهادفة جدا. واحنا بدورنا ايضا نحمد الله على هذه النعمه، نعمه التواصل ونعمه التكنولوجيا التي كسرت الحواجز ومكنتنا من التواصل مع زملائنا في كل مكان، وايضا من التواصل العلمي وتبادل المعرفه. الكلمه الان للدكتور خالد محمد الكحلاني. الدكتور خالد هو رئيس جمعيه المسالك اليمنيه، فليتفضل.
بسم الله الرحمن الرحيم. السلام عليكم جميعا، وجمعة مباركة، وإن شاء الله ما نطول عليكم بالكلمات مثل ما تفضل الدكتور عبد الله، ولكن هناك أشياء لا بد منها. أولا إحنا سعداء باستمرار هذه الأنشطة، ومثل ما تفضل أخونا الدكتور عبد الله يعني رب ضارة نافعة، وهذه هي الفائدة أو النفع الذي أتى من كورونا وتوقف المؤتمرات المباشرة وما إلى ذلك. كانت فائدة أن تعرفنا بجمعيات أخرى، وعلى رأسها الجمعية القطرية، الجمعية الطبية القطرية. أيضا زملائنا في المهجر الحمد لله يعني بيقوموا بنشاط يشكروا عليه في دعم زملائهم وإخوانهم في الجمهورية اليمنية. جمعية المسالك البولية اليمنية تتقدم بالشكر الجزيل طبعا لكل من ساهم في إعداد هذا الويبينار، وسواء عن الجمعية القطرية، سواء أطباء اليمن في المهجر، وأيضا الزمالة والفيلوشيب الاندورولوجي في جمهورية العراق الشقيق. احنا يعني يمكن سعداء أكثر أو خصوصية أكثر اليوم أنه بنحصد خير وثمرة زملائنا وإخواننا أبنائنا يعني الأطباء وزملائنا في المهجر، وهم زملاء أعزاء يعني، بحيث أن من يدير الجلسة والجزء من المحاضرين دكتور مرشد صلاح والدكتور عبد الإله والدكتور شكري، هؤلاء يعني زملاء أعزاء، وإحنا سعداء أنهم الآن بيخدموا ويقدموا الخدمة لزملائهم ومنهم أصغر منهم وزملائهم أيضا في اليمن. هذا مصدر فخر وسعادة لنا، وأيضا نتشرف بالزملاء الآخرين الدكتور عمار والدكتور طارق، وأيضا مناسبة إن شاء الله أنه نستفيد منهم جميعا وننهل من علمهم، وأيضا نستمنى أن هذه اللقاءات تستمر. ونشكر من هم من وراء الكواليس، الدكتورة مريم وكانت معنا في اللقاء السابق، وأيضا من يساعدها في التنسيق والتنظيم لهذه الويبينارات. ولا أطيل عليكم، وشكرا جزيلا، وإن شاء الله ويبينار موفق للجميع، والسلام عليكم ورحمة الله وبركاته.
شكرا جزيلا دكتور خالد. دكتور خالد الكحلاني كما عرفناه دائما أشعل جذوة النشاط العلمي في جمعية المسالك اليمنية، ونفخر بوجود الدكتور خالد على رأس هذه الجمعية. شكرا جزيلا دكتور خالد. الكلمة الآن للدكتور حيدر العامري. الدكتور حيدر هو رئيس لجنة جراحة مناظير المسالك في المجلس العربي للتخصصات الطبية في العراق. نشكره على الحضور، ونشكره أيضا على المشاركة الفاعلة في التجهيز والإعداد لهذا الويبينار بالتواصل مع الزملاء في العراق. ونحن فخورون جدا بزملائنا في العراق وبكوننا معا. تفضل الدكتور حيدر مشكورا.
أشكرك دكتور. السلام عليكم ورحمة الله وبركاته، وجمعة مباركة على الجميع إن شاء الله. بالبداية أنا أكون مختصر جدا لأنه الكلام يطيل حقيقة على هذا المحاضرة والويبنر، وإن شاء الله يكون فائدة يعم على الجميع وعلى جميع العرب. أشكر بالذات الجمعية القطرية لجراحة المسالك البولية، وأشكر اللي دعاني بالذات الدكتور عمار ورئيس الجمعية والأخوة المشاركين جميعا في إعداد هذا الويبنر من الجمعية اليمنية وجمعية الأطباء في المهجر في اليمن، وإن شاء الله نكون دائما مشاركين بهاي الويبنر والمحاضرات، واللي تكون بفائدة تعم للجميع إن شاء الله. العراق فتح الآن أبواب هذا الفيلوشيب حقيقة مع الاندورولوجي، وإحنا بدينا بها صار لنا سنتين تقريبا، خرجنا معظم الأطباء، والآن إحنا بالاشتراك مع الجمعية الأوروبية أيضا في ويبنارات مستمرة أيضا في كل أحد أو سبت. والآن إحنا اشتركنا وياكم إن شاء الله بهذا الإعداد بهذا الويبنار، وإن شاء الله دائما نكون مستمرين إذا كانت السلسلة يعني مفيدة للجميع إن شاء الله. وأشكرك إن شاء الله. أشكرك دكتور.
شكرا جزيلا دكتور حيدر، شكرا جزيلا.
ممنون.
وأنا باسمي كممثل عن أطباء اليمن في المهجر أشكر الجمعية الطبية القطرية ممثلة بالدكتور عبد الله النعيمي، وأيضا ممثلة بمسؤولة الأنشطة العلمية الدكتورة مريم العمادي. كما أشكر بقية الزملاء من كل الجمعيات وأشكر الحضور، ونتمنى الفائدة في هذا الويبينار وأيضا في سلسلة الويبينارات القادمة التي نحن بصدد الإعداد لها. الدكتور ستكون نبدأ الآن الفعاليات العلمية للويبينار مع الدكتور مرشد صلاح. الدكتور مرشد معنا؟
نعم معكم.
أوكي.
نعم معكم.
مرحبا دكتور مرشد.
أهلا وسهلا.
نرحب بالدكتور مرشد صلاح، ويعني فخورون بأن يكون الدكتور مرشد معنا في المتحدث الأول في هذه الفعالية. الدكتور مرشد علي صلاح he is a senior consultant of urology, also he is a chief of surgery department, head of urology section in Hazm Bayrik Hospital, and also he is the head of surgical division in the hospital. Dr. Morshid, he's completed his medical degree from Hungary, and also he is graduated and finished his PhD also in Hungary from the University of Debrecen. Also, Dr. Morshid has a master's degree in health services management from University of Debrecen, Hungary in 2007. He worked as assistant professor urology and consultant urologist in the Department of Urology of University of Debrecen, Hungary. And after that, he joined Hamad Medical Corporation since 2012. He was a Secretary General of Yemen Urological Association between 2009 and 2012. Dr. Murshid, he has a large number of publications, and also he has a reviewer in multiple urology journals. He has the 26 impact factor, more than 550 citations. Dr. Morshid is member of Endurology Committee of the Arab School of Urology. He is editorial board member and reviewer of several international scientific journals. شكرا دكتور مرشد على حضورك، بإمكانك أن تتفضل الآن في المحاضرة الأولى عن Supine PCNL.
Thank you very much for the nice introduction. Thank you very much for the organizations for inviting me for this presentation. And I'll start. I don't have anything to disclose. Here are the outlines that I'm going to talk about. Little background, start of supine positions, advantage, combined surgery, and some interesting cases from our practice. In a historical background from the prone, I'd like just to mention 2 slides. The start of the PCNL was by a radiologist actually and urologist from Stockholm, Sweden. And they did the first case in 1974, but they published it only on 3 cases only in 1976. And the resume of their work is here. what interesting that the upper limit for PCNL was 15 millimeter only, which changed after that in 1982 to 20 millimeter, which is now the lower limit to do PCNL, because they were doing tract and dilated it for several days. And in the 10, 12 days, they were removing the stone. And just imagine, they were discharging the patient after 17 days. The second slide from Prone, this slide from about Professor Peter Alken from Mainz, Germany, who started also in the same year, in 1976, the ultrasonic disintegration of stones. And he developed the telescoping metal dilators. And if you see here, I brought this slide intentionally. If you see here how vertical was the axis that time, it is almost near here to the vertebra, because they were afraid from the abdominal organs. If you compare with the axis now, which should be parallel with the floor, how they were afraid before the era of CT scan and ultrasound. They didn't know the axis, proper axis. Regarding the supine PCNL, it started in Spain, in another European country, in Basque County, by Gabriel Valdivia, who first reported his experience in 1987. And that time they were putting the patients in complete supine position without any lighted position or any modified position. They just put 3-liter air bag below the flank, and they were connecting it to a mosquito here, so they were elevating or decreasing the flank as needed. In 1990, he published a provocative publication that why urologists still doing prone PCNL, and in Journal of Endurology. And in 1999, he, after 11 years of his start, he published 557 cases in Journal of Urology about his experience in supine position. Other big name is the Gaspar Ibarolozia, who is working also in Basque County in Galdacao Hospital. So this Galdacao is the name of the hospital, not name of urologist like the Valdivia position. So he did the position, he modified the position of Valdivia and named it in the name of the hospital. He put 2 legs in lysotomy position. And same elevation in the flank by airbag. But he modified it with the so-called Galdacao modified supine, Valdivia supine position. And in 2004, by putting the ipsilateral leg in extension and the other leg in flexion. So he could to access from down if there is need to access the upper tract. But again, he was putting the airbag below the flank with the mosquito to decrease the elevation. The position from that time changed. This is from our experience. Worldwide, they are putting the pillows here below the gluteal area and below the back, and leave the flank free, so we can move the nephroscope easily. Our friend Guido Giusti from Milano, Italy, who is a regular visitor to Hamad Medical Corporation, he was last year before Corona, he came to Hamad Medical Corporation. He tried to modify the position and give this to his name, but it is not yet spread, this name, Gusty Position. What he did, he simply took the swimming noodle of his daughter and covered it by towel diameter was 7 centimeters of this cushion, and the rotation of degree hit the patient to the other side is 15 to 20 degree, and the space between the edge of the table and the patient should be 5 centimeters or hand palm breadth in order to avoid the disturbance of the metallic border of the table during fluoroscopy. They were just putting this. One surgeon will turn the patient to the other side, the other will put the elevation below the spine. So it is one pillow, and after that they measure the distance. If need to correct, they can correct, and then the final position, extension of the ipsilateral side and flexion in the other side in order to access the upper tract from down if needed. In Yemen, our professor Tawfiq Al-Ba'dani did the first supine PCNL in 2003, and he published his experience with 36 patients in Saudi Medical Journal in 2005. Here in my previous work in Al-Wakra Hospital, I started in 2014. It was a combined operation with flexible, and it was presented in the Hungarian Urological Conference in 2015. Regarding the puncture, here this is from joystick technique to do the puncture in monoplanar view. Parallel with the floor. If there is no urine or no methylene blue is coming through from the needle, then for those people who like to do biplanar technique, they can rotate the C-arm 30 degrees towards the patient's head. And if the needle here, if the needle is above the calyx, here it is above, after rotation, it is above the calyx, means you are dead. You have to come back from the kidney, not to correct the needle there. You have to come back from the kidney and put the fluoroscopy in 0 degree again, and you go superficial, it means towards the abdomen, because we are in supine position. If the needle is below the calyx, the targeted calyx, it means you are superficial. You have to correct yourself by going deeply. Monoplanar axis, it is actually my favorite axis. I am doing it always since I started my training, and actually this, yes, here the axis, monoplanar axis, you can see the movement of the calyx movement and retraction of the moving the kidney and retraction of the calyx. This is a monoplanar axis in prone, and this one is in supine position. This one in supine is not working. So for this, it was our first case. Video now is not working. Can do it, yes, like that. So we're able to puncture the upper calyx because the kidney was down. This was the first surgery which we did, it was combined surgery. Here the fluoroscopy should be in 0 degree, in vertical degree. Why they don't like the colon, the prone? Because they are afraid from the retrorenal colon. As you know, the CT scan is performed in supine position. So this is the more physiologic position. In 1987, they did a study for 90 patients. So they did, who are going to have a surgery. They did the CT scan in a prone position, and they found that only in supine position, the retrorenal colon is around 2%. while in prone position, it was 10% for the 90 patients that they did for them CT scan in prone. And this percentage decreased to 5% if they excluded the lateral third of the kidney. So in supine position, the colon is far. It is farther than in prone position. Just laser pointer. You see here is the colon, and here is the axis in supine, and here the distance is more. And here is in prone position, the axis and the colon. So it is not true that in supine it is dangerous to, the retrorenal colon is more. And if you tell the patient 30 degrees, the colon also will be mobilized to the other side. What are the advantages of the supine PCNL? There are anesthesiological, urological, and management advantages. The anesthesiological advantage, that is the administration of anesthesia, is simpler, safer for patients who are having cardiorespiratory disease, and easier ventilation for obese patients. Disadvantage, urological advantage, they are operative time shorter, one dropping, and if you can combine it with flexible ureteroscopy at any time, and you can do simultaneous bilateral in the other side also at the same time. The surgeon can sit also, it is comfortable, and the approach to the upper calyx is easier because the gluteal area is not there, it will not disturb you, so you can turn easily to the upper calyx. And the other advantage, the spontaneous evacuation fragments is higher because of gravity. Management advantage, it is easier to put to position the patient, and it is better, you save time for spare time and staff, less occupational risk for shifting patient, mainly the heavy patients, less risk for pressure injuries also. For the testicles also, we are always observing the testicles when we are putting patients in prone position, and also the knees and other areas. And visual problems, some patients, because of the patient in prone, they used to have some problem in the eye or in the vision after the surgery. And less X-ray exposure because you are not in the field of fluoroscopy. Disadvantage for this, that mainly for thin patients, the kidney is hypermobile because it is not pressed by the table, but you can decrease this by putting your hand on the abdomen and try to fix the kidney. Or you can put a guide wire and take it out through the urethra, the so-called through and through, and you fix the end of the guide wire in the urethra, the other in the skin, and you can fix the kidney. It will not move during dilation. The other disadvantage is the long tract because we are lateral, but we can avoid this with longer amplats and longer rigid nephroscope. And also there is a disadvantage. It is the collapse of the collecting system because of the gravity. Why prone? Why people don't like to do prone? Because many surgeons learned PCNL from their mentor who practice the prone. Experienced prone surgeons are reluctant to change their practice. Myself also, I was reluctant to do that, but we have to follow the wave. Otherwise, we will not develop ourselves. Here, to compare the prone and supine, the Clinical Research Office of the Endurology Society, PCNL Global Study in 2011, they collected the data between 2007 and 2009 from 96 centers for 5,800 patients from 5 continents. And here, if you see, surprisingly in Asia, mainly in India and China, they don't like the supine. Only that time, maybe now this percentage increased. Same in North America. Here you can see supine only around 2%, and 98% from the 96 centers were in prone position. And in South America, where they are following the Spanish guidelines because of the history, because they are following the Spanish protocols. Here it is vice versa. Supine around 98%, and only around 1-2% prone position. In Europe, it was in between 24% for prone and 76% prone and 24 supine. In this, these are the comparison between the two techniques. The yellow colors are favorable for supine, the red color is favorable for prone, and the green colors is equivocal. There is no difference. So the complication, like grade more than 2, Clavian grade more than 2, or blood transfusion fever, they are less in supine. Here the average, you can see number of patients average 80% prone and 20 supine, and this is still, I think, valid with minimal increase worldwide. And the mean operative time stone-free rate is better in prone position. Failed procedure also is less in prone. Meta-analysis from 2016, about 13 studies, they measure the efficacy like stone-free rate, mean operating time, hospitalization, and the safety like complication, transfusion. They found that stone-free rate higher in prone, and the operative time is less in supine, and less blood transfusion also in supine. An interesting study published in 2019 from Brazil, they compared the 4 techniques, 400, each arm 100, around 100, prone 99, complete supine, original Valdivia, and Galdacao position between 2011 2016, and they didn't find any difference. Just one difference, which is a favor for the complete supine. They found that the operative time in complete supine is less because they don't mobilize the patient. There is no time to do even to tell the patient to the lateral side. This is the only difference they found. But this is only one study, and it was retrospective. Meta-analysis from 2019, 15 retrospective randomized control trials, around 1,500 patients, they found only a different operative time and rate of fever less in supine. Other parameters were, there was no difference in the other parameters. A systemic review from 2020, 11 randomized control trials, including this study between 2009 and 2019, and they found only one difference in the supine, that the major completion rate is lower in supine, and the stone-free rate is higher in prone. Other parameters were similar. They don't like supine because the reproducibility. They told it is difficult to reproduce, to be reproducible. Here, Galdacao group from Basque in Spain, they evaluated 134 patients, was operated by the expert, the creator, Gaspar Iparolozia, and 183 patients operated with other surgeons who just have initial training. They found that supine PCNL is feasible for use by different urologic surgeons, not only by the expert or the creator. The results depends upon the surgeon's experience, as like other surgeries. With training and selecting the cases at the beginning, it is possible to achieve competitive results. This published in Urology in 2013. This is from webinar from our friend Gusty. He summarized simply the advantage, disadvantage of both techniques. You'll mention only the advantage for the supine that we mentioned, the anesthesiological, urological, and non-urological, so-called management advantage. And here, combined approach, I can add also, you can do simultaneous bilateral to operate in the other side at the same time. Guidelines, European guidelines, in 2000, what they wrote. Both prone and supine positions are equally safe, but neither has a proven advantage in operating time or stone-free rate. Here I have to stop at the operating time. When they are calculating, I think they are calculating since the start of the puncture till the end, while it should be calculated since the start of the anesthesia. Because in prone position, they are not calculating after putting the ureteric catheter and turning the patient to the prone, which is taking the time, the difference time between the two is in this stage, which we avoid with by putting patient in supine. So any study that showing that there is no difference between the two techniques, I think they are not calculating the anesthesia time from the beginning. Now I'd like to continue with the endoscopic combined internal surgery, which is in some places, they start the PCNL with flexible. I will mention it later. Here, the different name for this technique, endoscopic combined internal surgery, or ECIRS, or simultaneous antegrade and retrograde endoscopic axis, or simply they are calling it PCNL combo. Types can be reverse lithotomy, prone split leg, lateral decubitus supine, and the commonly used Galdacao modified supine Valdivia position. This is the most commonly used position. Regarding the reverse lithotomy position, they published this in 1988 from US, reported 3 cases, mainly female cases. Here, we also did in my previous work with prone split leg in female. This is Dr. Janak Dizai, who was a visitor to our department. Dr. Shamsuddin, who was the head of urology. At that time, they did a nice surgery with prone position, combined surgery in prone position. Supine position, here this is the classic, but here you cannot insert a rigid scope. It's good if you have flexible cystoscope and flexible ureteroscope. And here is the commonly used position. We have to position to put the patient in extension leg, and the other leg is in flexion. Here. Again, yes, here I would like to show you one from our experience here. This is our first case. There was in the parallel calyx, there was a stone which we couldn't, if you see here, we couldn't reach here. So we prepared for that from the beginning. We went with flexible ureteroscope. Here in X-ray, you can see how the flexible and the nephroscope. So with nitinol basket, the so-called engage, we catch the stone and passed it to the nephroscope, the so-called pass the ball. And we catch it with the forceps and we removed it. With this, we can avoid any additional tract. So if we are using endoscopic combined surgery, we should not do multiple tracts. Here we have catch it and we removed it. Disadvantage, you need 2 from everything, 2 urologists, 2 scribnas, monitors, lithotripter, one of them should be laser because for flexible. And also it is expensive because you need to have flexible ureteroscope is not available in a lot of places. Here, just from 2004, Galdakao group, also they published 1,000 cases supine and 300 combined, and didn't have any colonic injury. Stone free rate, another group from Italy. In the first session, 82%. In the second session, 87%. From France, a group from France, but 47 cases. Single stone, 90%. Multiple stone, 74%, and it decreased staghorn stone to 43%. A study from 2015, here they found that the stone free rate is 65%, and it depends on the stone size and the location in the calyces. This name, endoscopic combined internal surgery, came from Torino, from Cesar Scafona from Torino, who has very nice book about supine and endoscopic combined. And he is starting his supine with flexible always, and he is doing the puncture under endovision. So he is following the puncture and the dilatation with the scope from down. He published review in 2020 in Turkish Journal of Urology, 14 studies, different systemic review, randomized, non-randomized, case series studies, and he found a stone-free rate around average 80%, the complication between 5.8 till 44%, operative time 70, and surprisingly hospital stay between 5 and 9 days, which I find it is a little high. I can advise for you a good video in the surgery in motion in European urology from France group in 2012 with simulations. I can advise for you this video from European urology. It can be beside endoscopic combined. You can do also simultaneously at the same time, not in the same session, not single session, simultaneous. One surgeon working in the other kidney, other surgeon working doing flexible in the other kidney. There is a study on 27 patients published in European Urology 2018 from Guido Gusty group, and they found that there is no change in creatinine and the filtration rate compared to the baseline, and they didn't have any major complications. So this also achievable. Finally, I'd like to show for you some interesting cases from our practice. Here, this is see here staghorn stone. It is you can see it here more in the video. Right kidney stone. So we could achieve almost 100% result with endoscopic combined technique. Here we did 2 surgeons. We were there in the theater, and here the single use ureteroscopy. Maybe for those who can have single use, it is advisable because you can have a lot of fragments stone, so you may injure the reusable one. It is advisable to use the single use. And here our post-op is almost stone free. Here the gases, we cannot see it exactly. Another case, you see here staghorn stone, single session, single tract, and supine PCNL. we could reach the whole calyces, all calyces from the lower calyx. This is without contrast. This is the stones, and when we, before putting the uretary catheter with balloon, you see so many stones, and we could reach here. If you see, we could reach almost 100% clearance, stone clearance. Here you can see during the lithotripsy, we found some tissue like inside the stone. This we catch it and removed it separately here. Send it for histopathology, fibrosis with polarized crystals. This another video here, you can hear the sound. This is the trilogy, which is ultrasonic, electrokinetic, and suction at the same time through one probe. And you can see here dust and fragments. All these fragments came through the 3.9 millimeter probe, those removed by forceps. Last case, it is interesting case. It is daycare, tubeless, supine, under spinal anesthesia for partially staghorn stone. And the patient stayed in the hospital only more than half day. Here, the doctor of anesthesia giving the anesthesia, high spinal anesthesia between L3 and 4, the position. And here, the position, we have to tilt the patient. So some people are asking till which degree you should tilt. You have to tilt till the stone reach to be beside the vertebra. And here we could reach stone clearance. And here the patient spent 13 hours, 40 minutes. Of course, this urine was during evening round, it was clear. So the patient discharged home, and we have consent from patient to show his picture just for confidentiality. And thank you very much for your kind attention.
Thank you, Dr. Morshid. Thank you for this fruitful presentation. Just I have to announce to our colleagues that the discussion it will be at the last of the this webinar, inshallah. They can write their questions in the question and answer. There is here a button or logo for question and answer. They can put their questions, and we are happy to introduce these actions to speakers. Another important thing that we are glad to have Dr. Pal with us. Dr. Pal, he is a PCNL pioneer worldwide, and he is a famous senior urologist in India and international figure in Endurology. Dr. Pal, how are you, Dr. Pal?
Thank you, doctor. I am very well. And I am really very happy to join the group. And enjoying the first talk was excellent, covering more than what I expected. Great talk, and I am there to listen to you. Thank you very much.
Thank you, Dr. Pal. Thank you so much. We are glad to have you here with us.
Thank you. Thank you very much.
We have, before to go to the second presentation with Dr. Tariq, I mean, we have a poll. Please, you can answer this poll in 30 seconds. After that, we will go to the second presentation. Okay, so for the results, do you perform PCNL? Yes, 97% of attendees, and only 1% who are not doing PCNL. Which position? 64% of the attendees doing prone position, only 21 who is doing supine position. I think there is also third question, or only two questions. Okay. Can we go to the third question about planning? Who's planning to do supine PCNL? The directory board of the webinar, please. We need the third question in the poll. Who is planning to do supine PCNL in the future? Okay, so we can go to this. Yes, are you planning to change to supine PCNL?
This should be at the end, this one.
We want to see before the presentations.
Because here the third one is...
Yeah, only one question. Are you planning to change to supine PCNL? And also because Dr. Tariq, he will talk about the mini PCNL. We want to see how many who's doing mini PCNL. Okay, so the result, there is 83% of the attendees who also planning to change to supine PCNL. I think this number will increase at the end of this webinar. 94% are doing or performing mini PCNL. That's great. So it is a good percent. Okay, so now we can go to the second. Okay, so we can go now to the second presentation with Dr. Tariq Amin. I'm glad to introduce Dr. Tariq. He is a urology consultant at Hamad Medical Corporation. He was graduated from the Medical Faculty of Alexandria University in Egypt. Then he joined Hamad Medical Corporation, where he completed his urology residency and obtained the Arab Board certification, MRCS, and then the Endourology Fellowship program that was supported by his training for miniaturized PCNL technique in China under the supervision of Professor Zeng. Dr. Tariq has several publications and in the field of endourology. He has also a reviewer for multiple urology journals and a member of various international urology associations and a member of the Qatari Board of Medical Specialties Examination Committee. Dr. Tariq, please, you can start.
Thank you, Dr. Shukri, for your introduction. Can you hear me well?
Yes, yes.
Okay, great.
Yes.
All right. Just before I start, I would like to introduce our facility, Hamad Medical Corporation. It is the main provider of secondary and tertiary healthcare in Qatar. It manages 12 hospitals. And this is a picture of Hamad General Hospital, which is the largest and main teaching hospital at the heart of the capital city, Doha. And this is the ambulatory care center where we perform most of our endourology procedures. I work at HMC and I don't have any disclosures to declare. Before I start my presentation, these are the outlines that I'm going to talk about. First of all, I'm going to talk about the history of miniaturization of PCNL. Then we'll go to the definitions of miniaturization with the different variants of mini PCNL. I'm going to speak briefly about each variant and what are the main differences between each and what are the problems that are encountered with the conventional PCNL. Then we'll compare between the mini PCNL and the conventional and compare between the variants themselves and just few considerations about supine mini PCNL and take-home messages at the end. Being an endourologist, actually, I love this slide. This is the history of endourology and PCNL. It starts in 1879 when Nitz and Litter performed the first cystoscope. Then in 1941, Rupin and Brown performed the first nephroscopy during an open surgery. In 1955, Goodwin performed the first percutaneous nephrostomy. And then with the advancements of the fiber optics, in 1976, Fernenstorm and Johansson performed the first percutaneous nephrolithotomy. Again, with the advancements of lithotripsy, ultrasounds, Professor Smith kept on evolving the PCNL procedure, dilatation methods, stenting, and till 1983, when he established the Endourology Society with a collaboration with Dr. Segura, Clayman, Baldani, Alkin, and Namplants. And with the advancements of pneumatic lithotripsy, the first miniaturized PCNL was done in 1998 when Dr. Jackman performed it in the pediatric population. Then in 2007, Dr. Negil performed the mini PCNL in the adult population and performed the scheme of MIP, minimally invasive PCNL, from which Karl Storz applied their MIP set. Then we'll go further with the advancements and the evolution of miniaturized PCNL. The Chinese mini PCNL was performed in 2009 and was reported by Li et al. And the difference here was, I'll go through this in details later on through my presentation. In 2012, Dr. Mahesh Desai performed the micro PCNL with a 4.8 size track, all-seeing needle, to reduce the complications as much as possible. But there were some problems. So in 2013, Dr. Sabnis went into a slightly bigger size, which is 8 French, using the mini micro PCNL. And in the same time, Dr. Janak Desai performed and the ultra mini PCNL, introduced it to us with 11 to 13 French. Then the advancement went further with Professor Zeng in 2017 when he introduced the first generation of SMPs, super mini PCNL, with the suction, and 2018, the second generation. For this nomenclature and without standardization, Dr. Wright and Somani provided the nomenclature way of PCNL. That's how should we report PCNL. Like saying, considering the position, whether it is prone or supine, the sheath size ranging from 4.8 to 34, mode of fragmentation, and the presence or absence of the tubes at the end of the procedure. So when we report the PCNL, we can just mention like P30U and PCNL, or S18, LA, laser, or TT, putting total tubeless PCNL, for example. Let us go through the different technologies of miniaturized PCNL. So this is the Karl Storz system, MIP, which is differentiated into XS, MIP XS with a 9.5 French, which is as an alternative for the flexible ureteroscope for when if it is inaccessible in flexible ureteroscope is unavailable or unable to reach the kidney through the ureter, we can use the MIP XS. MIP small when the size with a size of 12 up to 12 millimeter stone can be used, and a medium size with a 17.5 French for stones up to 24 millimeters, and the large size for more than 24 millimeters. The Chinese mini PCNL, the only difference between it and the Nagil system is adding the automated irrigation pump, which is alternative. The first picture I'm showing here the pointer. This is the vacuum effect that was reported by Dr. Nagil and of how to remove the stone fragments during mini PCNL, and it was enhanced by the Chinese pump. This is the ultra mini PCNL. It is, as we mentioned, it is 11 to 13 French sheath. The sheath is having an inner lumen for irrigation, which increases the whirly effects and increases or enhances the vacuum effect that is performed in mini PCNL. So in small stones, you can remove the stones fragments easier and faster. Regarding the SMP, I would like to show you here the video. It's not opening. Okay. Sorry.
So Tarek, with the laser pointer, it will not work. Maybe
I'm trying to end the show actually. Okay. Here it is. This is a demonstration of the SMP. This is the nephroscope, a small size nephroscope from which we can add irrigation. And the sheath, this is actually the second generation SMP. The sheath is having dual irrigation system. So the irrigation is enhanced a lot so as to improve the vision, which is the main problem during miniaturized PCNL. With such system, the irrigation helps the stone to be pulled toward the sheath, enhanced with the suction. The fragments are pulled automatically towards the suction sheath. So the procedure is easy, simple, with good visualization and removal of the fragments, easy removal of the fragments with a very steep learning curve. This is actually the clear Petra sheath that is booming in the market right now. It applies the principle of the first generation of SMP without having irrigation through the sheath, but only a suction. So it's a mini PCNL with adding the suction. It comes in different sizes ranging from 12 French up to 26 French with different lengths starting from 15 centimeters to 21 centimeters. It is really good when it is applied for miniaturized PCNL and allows enhanced clearance of the stones with reduced intrarenal pressure. This is the micro PCNL that was introduced by Dr. Mahish Desai in 2012. This is the 4.8 French all-seeing needle. It allows the entrance, the precise entrance to the calyx, avoiding the infundibulum, seeing your point of entry while putting the needle in, and through which we can insert a small laser fiber of 200 microns to laser the stone, dust the stone without keeping bigger fragments. The only problem of such procedures that we cannot remove any of the stone fragments out. So the question is, why shall we miniaturize PCNL? And accordingly, to answer this question, so what is the best PCNL? So the best PCNL is having the trifecta of removing the whole stone in one session with a complete stone clearance, and in the same time, avoiding any complications or morbidity. And the third important issue is the cost effectiveness and the patient satisfaction post-operatively with pain and early discharge, going home early and resuming his daily activities and work. So although PCNL was considered as a minimal invasive procedure when compared to open procedures for removal of the stones, for that reason, open surgeries became nearly obsolete or very rare to be done. However, PCNL is still having some problems, the most important of which is bleeding. This is the CROIS study, global study that was performed, evaluating the PCNL all over the world with having a 7.8% bleeding rate, which is still significant, and we're trying to reduce this rate as much as possible. The second problem is the affection of the nephrons, causing nephrons loss and affection of the renal function. The third issue is the perforation in the pelvic calcaneal system and the tears that happen with persistent leakage post-operatively. The third problem of PCNL, the inability to access some of the calyces with one point of entry. So sometimes we need to have multiple tracks, multiple points of entry. With multiple tracks, again, we're increasing the complication rates of bleeding, renal function, perforation, pain, and the tubes post-operatively with the hospital stay, and accordingly, the cost will be raised. Regarding the infection rate, which is 10.5, we'll go through it if mini PCNL is reducing or increasing the rate of infection or as it is. The first comparison that I would like to present is a very nice study that was performed in 2017 by Dr. Emiliani, Dr. Traxer, when they performed it on pigs and cadavers, comparing between different sizes of tracks ranging from 11 French to 30 French, comparing different techniques of dilatation, whether it is amplet serial dilators or balloon dilatation. We can see obviously the main difference when we go from 11 to 12 French or going to 30 French with this big tear. Whether it is balloon or amplets, it didn't matter a lot, but for both pigs and cadavers, the tear was more significant rather than the small caliber tracks. So beyond 18 French, the tear was found to be more. The second, then I need to go through the complications or the problems that we mentioned. The CROIS global study again was performed and showed that one of the conclusions that was presented, that the larger the bore, clearly it increases the chance of bleeding. This is another systematic review that was recently published, confirmed the same findings, that mini PCNL provides less bleeding complications, less pain post-operatively with tubeless PCNL, and a less hospital stay. There was no significant difference in stone-free rate between mini PCNL and the standard PCNL for stones less than 2 centimeters. They also mentioned that the complication rates are inamenable, whether it is mini PCNL or conventional PCNL, if we're having untreated preoperative UTI, or with high perfusion pressure, which is significant in mini PCNL, longer operative time, again in the mini PCNL, with the pelvic calcaneal system perforation, which is going with the conventional PCNL, and poor drainage of the pelvic calcaneal system after surgery. So the nephrostomy tube after surgery provides good drainage, extra drainage with the double J stent whenever needed, and it provides tamponade effect for the track itself, and allows a second look if it is needed within few days, while the tubeless PCNL provides a better post-operative pain with early hospital discharge and resumption to work. The final conclusion of this study, they mentioned that the most important key denominator for optimal stone-free rate, which is defines between mini PCNL and the conventional PCNL, is the stone burden. The second important issue is the renal impairment that occurs after PCNL. A recently published study in 2020 utilizing the 3D planimetry, they mentioned that they found that a decrease in the total kidney volume post-PCNL, especially for those with larger stone surface areas, with larger bore calibers and history of previous PCNL. Another study confirmed the same findings with the multi-track axis that we're reducing the renal function with the more tracks that we perform. And this is a study performed on mini PCNL, and they found that the multi-tracks was the most important and the only independent unfavorable risk factors for having a worse outcome post PCNL or mini PCNL. So what can we do for multiple stones, bilateral stones, staghorn stones? Usually in such cases, we can perform just only one conventional track, while the complementary tracks should be done with miniaturized PCNL. Otherwise, use the endoscopic combined intrarenal surgery as illustrated by Dr. Morshid. Regarding the infection, mini PCNL is blamed for two important risk factors that are really important for the infection rate, which are the operative time, which is more with mini PCNL. Regarding supine versus prone, it is a bit debatable. The other issue is the intrarenal pressure, which is actually a very important issue with the PCNL infection rate. This is a good study by Dr. Zeg that was performed in 2007, evaluating different tracks of mini PCNL. He found that the smaller the caliber of nephrostomy tube, the higher the pressure. The mean pressure was higher, of course, and the time that needed be above the cut point, which is 30 millimeters mercury, above which complications are expected, was found to range between 280 seconds to 10 seconds between the sizes of the nephrostomy tubes. If we compare between the mini PCNL subtypes or the variants, the first comparison between the ultra mini PCNL and the mini PCNL, a study that was performed in 2017 found that for stones less than 2 centimeters, ultra mini PCNL was causing less bleeding, less hospital stay, less for blood transfusion, and less post-operative pain with more tubeless procedures, with equivalent operative time and need for auxiliary procedures and stone-free rate post-operatively. The debate was still up till there until a recently published study in 2020 when they compared between the conventional PCNL with the mini PCNL and the ultra mini PCNL. Actually, the ultra mini PCNL was inferior to the mini and the conventional for the stone-free rate. It was having better complications. That was not that much different from the mini PCNL. So the overall evaluation favored mini PCNL with 18 French rather than ultra mini PCNL or the conventional PCNL. For the SMP, the super mini PCNL, this study was done in 2018, and they showed that it provided equivalent stone-free rate with equivalent operative time, equivalent complication rate, and less systemic inflammatory response syndrome, and more tubeless procedures and less hospital stay. This is when it is compared to the mini PCNL, not the conventional PCNL. Again, this was done for stones less than 3 centimeters. Another study performed by the same group evaluating why was there systemic inflammatory response syndrome that is less than the mini PCNL. They found that the intrarenal pressure of SMP is really low compared to other miniaturized PCNLs. That's because of the suction that is used. during the procedure, reducing the intrarenal pressure. So a good with experience actually, and knowing the rate of irrigation with the suction, it is important to equalize both, or keep a pressure in between 30 millimeters mercury all over the procedure, with the suction reducing the pressure during the whole procedure. This is very important for it. This is another study that was recently published evaluating the super mini PCNL. It was a multicentric study, and our center was involved in this study. The SMP showed advantage over the mini PCNL for the stones less than 3 centimeters, while beyond 3 centimeters, the mini PCNL was much better. The SMP showed less pain postoperatively, with less tubeless procedures, less hospital stay, and equivalent fever postoperatively, and systemic inflammatory response syndrome. Regarding the micro PCNL, this is a systematic review that showed only 3 studies were evaluating the micro PCNL in the literature, evaluating stones for 13.9 millimeters. They achieved a stone-free rate about 89%, with an mean operative time of 80 minutes, which is a lengthy procedure for 13 millimeters stone. But we can mention this is because of the dusting way of breaking the stone or dusting the stone that is equivalent to the flexible ureteroscope. A hospital stay of 2.2 days, with a transfusion rate, a very low rate compared to miniaturized PCNLs with all variants reaching 0.8%. However, the Steinstrasse rate post-operatively was reaching 28%, which is really significant post-operatively. With the advancements of the thulium fiber laser, again, the micro PCNL came into the PCNL's studies. The recently published one evaluated the micro PCNL with thulium fiber. It was done for stones up to 19 millimeters. They obtained a stone-free rate reaching 92%, with operative time, which is 55 to 105 minutes. However, the lasering time was only 8 minutes, plus or minus 6, with a complication rate, which is really important for further evaluation, infection rate of 7%, Steinstrasse 7%, and hematuria of 7%, with a hospital stay of 3.4%. Multicentric and RCTs, more RCTs with bigger numbers are needed to evaluate such procedure. Regarding supine mini PCNL, it allows multiple important advantages. As we know, in the supine position, the kidney is more mobile, so it is advisable to perform the dilatation in either a single step or a balloon dilator. So for the miniaturized PCNL, most of the time we are using one-step dilatation method, which is really good for such a mobile kidney in a supine position, rather than the conventional PCNL. Otherwise, we should use the balloon dilator instead of the amplat serial dilators. It allows faster drainage rather than the prone, because the stone fragments go down with the gravity, so easier stone retrieval and faster drainage. It allows easier endoscopic combined intrarenal surgery, as illustrated by Dr. Murshid, especially for those stones with multiple calyces or upper urethral stone, where we can push the stone to the pass the ball to the PCN track, or guide the puncture to have a precise entrance. Or at the end of the procedure, we can confirm complete stone clearance after PCNL, confirming that there are no even a tiny fragment remaining in any of the calyces in the kidney. It also allows a very important and nice thing to insert the stent retrogradely with threads, or a urethral catheter that is removed just only within 1 day. We can remove it and the patient can go home. So as a summary, this was a study in 2017, a critical review. evaluating mini PCNL techniques. They mentioned that indications are not yet standardized for mini PCNL. However, good outcomes with lower complications rates are achieved compared to conventional PCNL, and higher cost effectiveness when compared to flexible ureteroscopy. At the end, each patient needs to be considered individually and tailored surgical treatment. Still, conventional PCNL is important, especially for stones larger than 3 centimeters. It provides better and higher stone-free rates with less operative time, better visualization, and less intrarenal pressure. However, mini PCNL is really considerable for stones less than 3 centimeters. It allows less tear, scar, and bleeding complications, conserving renal function, which is affected by the dilatation. It allows better multiple tracks and easier manipulation throughout the whole calyces. More tubeless procedures are obtained with less post-operative pain and shorter hospital stay, and consequently, it is more cost-effective than the conventional PCNL. At the end, we would like all of us to end the pandemic of the COVID era, before which we used to perform our Endurology workshops. We would like to resume it once the epidemic is over, and invite you all to join us and enjoy Qatar. Make sure that you'll find your friends in Qatar, making sure you will enjoy it the most. Thank you so much for your attention.
Thank you so much, Dr. Tariq. Actually, it is interesting, comprehensive presentation, and also we enjoyed it. I don't know, maybe because I like mini PCNL. Okay, I hope all the attendees also enjoy this presentation. Also, we want to announce again that the discussion, it will be at the last of this webinar. And we can use the question and answer button or logo. Just press in this logo. It is in the bottom of the screen, and you can type your question, and please mention the name of speaker if you want one speaker to answer you, or it is if your question related to one presentation. Now we can go to the next session. Next session in this webinar. It is a semi-live session with Dr. Ammar. There is surgery already prepared for you today. Dr. Ammar, are you ready?
Yes, I'm ready, but I want to share.
Actually, I'm glad to introduce Dr. Ammar. Dr. Ammar Al-Ani is a senior consultant of urology and endourology in Hamad General Hospital, Hamad Medical Corporation. He is an instructor in clinical urology in Weill Cornell Medical College in Qatar. Dr. Ammar joined HMC in 2003, and he obtained the MRCSI from the Royal College of Surgeons in Ireland, and after that the certificate of Arab Board of Urology. Then he get the fellowship program in urology in Qatar. During his fellowship, he did training in endurology with Professor Oliver Traxer in Paris, France. And Dr. Ammar, his clinical interests include the minimal invasive management of urinary tract stone, including shockwave, lithotripsy, percutaneous, and ureteroscopy stone removal. Actually, he is doing a great job in this field. Dr. Ammar is developing and chairing and developing of curriculum of urology fellowship in Hamad Medical Corporation, and this fellowship according to ACG MEI guidelines. His passion in teaching this make Dr. Ammar the best we can call. Yes, he is the best teacher in this field and in Hamad General Hospital, and actually he is awarded twice the best teacher in 2012 and 2013. Dr. Ammar, please, you can start.
Thank you, Dr. Shukri, for this nice and lengthy introduction. That's more than required. I hope you can hear me well and you can see the video. You can see?
Yes, you can start the video. We can see.
Okay. بسم الله الرحمن الرحيم. السلام عليكم جميعا. جمعة مبارك. I'm really happy in this meeting to see our colleagues from Qatar, Yemen, and my home country, Iraq, and also happy to see our friends and colleagues from India, namely Dr. Pal. That's very nice opportunity to see our friends during this pandemic. And as Dr. Naimi said, this is one of the advantages of coronavirus. Okay. My presentation is a video presentation. It's a semi-live surgery. And at the beginning, I want to really thank my colleagues, Dr. Hamza Shahad. He is the fellow. He assisted me in the surgery. And my dear friend, Dr. Ardalan Ghafouri. He is a colleague here in our department, and he's a great photographer. He helped me a lot in producing this video. I'll concentrate on the practical aspect of the supine PCNL, starting from the, let's say, access to exit. Okay, we start with the positioning. First, I would like to say that we have consented this patient for photography, and he agreed, and he knows that this is educational video and it will be published internationally. This gentleman, 30 years old, he has a straightforward 3 centimeter stone in the renal pelvis, no history of intervention before. We counseled him for supine PCNL and he agreed. We start with the position, and as mentioned previously by colleagues, that we put a pad just to tilt the patient 15 to 20 degree up. We tilt the flank, as you can see here in the video, 20 to 30 degree up. Okay, and actually I adopt a Gusty position where I keep the ipsilateral leg straight, which is very, very handy. And compared to the Valdivia position where you put flexion here, it's difficult when you have instrument come to the upper pole from here, as you can see. So I keep the ipsilateral leg position straight, and the contralateral leg will be in the stirrup or in the boot. The landmark here, we have 3 main landmarks for the puncture. We have the upper border is the costal margin. As you can see here, I'm delineating the costal margin. And down we have the iliac crest. And we have, our limit is the posterior axillary line, and the study that showed it's very unlikely if you review the CT properly and go above the posterior axillary line. Sorry, if you don't go above the posterior axillary line, you will not end up with colonic injury. So this is the safe area. This is we call it the safe zone. This is the safe zone where you introduce your puncture. Here is the refraction of the posterior peritoneum is here. So most of the time you don't have any viscera in this safe area, and you can puncture safely here. Above we have the lungs and the diaphragm, and down we have the bone. So this is the safe area for puncture. And after the marking, we put the safe point, which will be in the middle of the field. This is happening before draping. Before you drape the patient, still, okay, the patient in preparation. And before you put the boot, I do always the marking before I put the contralateral leg up, okay? Then I will lift the contralateral leg up. The C-arm is in the field, and the arm here is above the chest, and make sure it should not intervene with your X-ray field. So this is what is called Gusty position, and I adopt this position and use it routinely in our OR in the ACC. And before you drape, it's better to check the position before you drape, because it's very difficult to adjust the position after you drape. And you should see the stone just lateral to the spine. Here we have a stent, stented before, and if the stone is lateral to the spine, you are in correct position, then you start, okay, painting and draping. You drape both. You drape the flank and the genitalia, because as mentioned earlier, we can do combined approach. Usually the assistant stand in between the patient legs, so that he can introduce any instrument in the retrograde fashion, and we leave the area of the puncture with a transparent drape, and this is the nice drape that's used for percutaneous nephroectomy surgery. I always arrange the table before procedure, make sure that armamentorium are ready, nephroscope, semi-rigid ureteroscope, balloons, guide wires, the cables, all the instruments, contrast, all these things should be ready before you start the procedure. Assistant usually start in retrograde fashion and go transurethral. Gusty, our friend, insists that use flexible cystoscope to go and cannulate the ureter, but in my experience and our experience in HMC, we use semi-rigid ureteroscope and we find it quite easy to cannulate the ureter. Here, luckily, the patient has a stent, so it's much easier also to cannulate the ureter. You can see the stent is here, and it is not really a long duration, not very much encrusted the stent. We take the stent out, and one of the tips and the tricks, when you remove the stent and it is not encrusted, you just pull it to the tip of the urethra, and you can insert the guide wire directly inside the stent into the ureter, and this will save you some time, and you can use it both for ureteroscopy or for putting the catheter for percutaneous nephroectomy. Then after, I use open-end catheter. If you have occlusion balloon, it would be better, but both are used and feasible. Open-end catheter, you put it just below the UPJ. The catheter should be introduced over the guide wire smoothly till you reach just below the UPJ, and this is the area where you need to stop. And here you start to inject contrast and visualize the system. You see here, this is the guide wire under fluoroscopy, and then the catheter. After introducing the catheter, we do retrograde study to visualize the calyx, the calyces. And here you need to really design your puncture. When you look at this, you have here the upper pole is big, and the middle calyx here, and the lower calyx. Okay, most of the time in supine PCNL, most of the time, if the stone here in the renal pelvis, you can access from the lower posterior. Nevertheless, we can go also into the middle calyx. Here you can see under fluoroscopy, and then you can design your puncture before you go in. You put the needle outside on the top of the patient, and you can see the direction of the calyx under fluoroscopy before you start the puncture, so that you know your direction, because kidneys are very variant, and patient to patient you have very significant variation. So always I put the needle on the top and see the direction of the calyx, so that I can design my puncture. You can see the needle is here, and you can see under fluoroscopy here, and you can. And I'm choosing, if I want to go to the middle calyx, I'll wait till the kidney to goes down, then puncture the middle. If I want the lower calyx, I want for full expiration. The movement of the kidney is very important here when you do the puncture, because it will trick you if you don't follow it properly. And always do it under fluoroscopy. Monitor the movement and do under fluoroscopy till you really find the ideal calyx and puncture it. And you should design your puncture. My puncture here is designed to go to the lower calyx, so that I'll wait for the kidney to be really high up in position. Then I hook the needle inside it. The plane here is the needle is parallel to the ground. You can see just parallel to the ground. And most of the time, if your tilt is ideal, you will find the right direction. You can see here I'm introducing the needle. Then you will see a moment where you hook the kidney, where you reach the capsule. You can see the kidney still moving. Then the needle at a moment will hook it, and like start to move with it. You can see the needle and the kidney are moving in the same way now. You can see I hooked the kidney and start to move. Then you see flattening of the papilla. And this is one of the signs that you are in. You see the movement of the needle with the kidney and you flatten the papilla. And always I do biplanar to make sure. I go to the 30-degree and have a look. How does it look in the 30-degree? If it is above the calyx, then you should go more anterior. If it is the needle below the calyx, then you should go more posterior. If you imagine it, it's difficult to imagine. If it is above, you go above. It is below, you go below. I call it follow the needle rule. Follow the needle. If the needle is above the calyx, you need to go more anterior. If the needle is below the calyx, you just go more posterior. Just follow the needle. Don't think it too much. Here I adjusted. I found the needle a little bit above. Then I pull it and I'm introducing it again to make an ideal puncture. I'm puncturing the same calyx, and you can see the flattening of the papilla during the puncture. Then you feel the pop when you enter the papilla. Actually, you will feel it with your hand, and this is very important feeling so that you don't advance the needle more. When you feel the pop, you just pull the stellate. And thanks God, this puncture was straightforward and directly a clear urine coming, and my assistant is pushing some saline from down to enhance it. Then
دكتور عمار
Yes.
عمار أعتقد if you can make the picture smaller so that we can see everything. It is so big that we don't see everything. We see just part of the procedure. Can you make it
picture?
Zoom out or minimize minimize it?
Just a minute. Minimize the which one? I'm not very good in Zoom, by the way. Okay, so
because it's
what?
really big. The picture is big that we don't see everything. Yes, I think that's fine.
Now, okay, you can see. Let's go back a little bit for the puncture.
Yes, please. We could
Let's
not
see again.
everything.
The puncture, you missed it.
Oh,
you
everything.
Did not see it?
We missed everything.
Really? Oh my God. So I don't know. I go from the beginning, or what do you suggest?
I think it's better. This is very important. If you don't mind, and
because this is
the
crucial part.
Yes, yes.
Who else can suggest? Okay, let's go from the beginning quickly. I'll pass it.
Yes,
so
please.
Okay, Dr. Amar, you can start from the puncture. From the puncture, you can start again.
From the puncture?
Yeah, from the puncture.
Okay. Okay, from the puncture, we can start from the puncture. Just a minute, let me see. We are removing the stent here. We can start from the puncture. Okay. I hope now it will work. Now you can see it better. You can see the retrograde picture.
Yes, it's clear now. Yeah, yes, it's clear.
Now it's clear. You can see the retrograde, and now the needle is outside, as I mentioned earlier. So I choose my direction and I choose the calyx. And I'm choosing the calyx now. I choose the lower calyx. So I wait for the kidney to move up while I'm puncturing the lower calyx. And this is very important. If I'm going to the middle, I'll wait for the kidney to go down. This is my safety area, safe zone. And this is the needle. Okay, we'll make a small slit with the knife. And then we start our puncture. Okay, you can see, I hope that it's clear now. This is at the level of the skin where we had our mark. And now I'm introducing the needle, and look at the fluoroscopy. We repeat it again. And this is, I think this is the most important point in the whole procedure. If you miss it, if you don't do it properly, you cannot really do a proper supine PCNL. Here I'm introducing the needle under fluoroscopy, and I wait for the kidney to goes up. Then I hook the capsule. Then when I hook the capsule of the kidney, I feel that the movement of the kidney is with the needle in the same plane, the same direction. You can see now I'm moving the kidney. Then the second sign is the flattening of the papilla. The papilla is flattened. Then you pop it. You feel the pop And once you feel the pop and you are in the calyx, don't introduce the needle furthermore, because it will be traumatic if you go through and through. Avoid over dilation and avoid over introduction of the needle. I do always biplanar, as I said. I check with the 30 degree to the patient head, and you can see there is a movement of the needle here, but it will be shown later in the video. I asked the X-ray technician to move 30 degree to the patient head. You can see the movement here. Okay, the needle is moving with the kidney, and this is a good sign that I hooked the kidney, but I want to make sure that I am in the right place. I adjusted the needle here, I pull it back outside the kidney, then introduce it again to make sure I am in the proper position. I'm pushing now the papilla, flattening the papilla, and now the needle is inside the calyx. Then I make sure, okay, I make sure when I remove the stellate that the urine is coming, not the blood. And here it's urine, and some saline is pushed by my assistant in retrograde fashion. After that, we introduce the first guide wire. I use solo guide wire. My aim most of the time is to enter the UPJ and put the guide wire in the ureter. Nevertheless, if I don't find way, and there is a big distance here where you have coil of the guide wire inside the upper calyx, no need to manipulate a lot. Just coil it in the upper calyx and pull the needle back. And because too much manipulation will not help, you don't mandatorily, not necessarily that you go into the ureter every time you do PCNL. It's better, it's a good practice, but it is not mandatory. If you have a good distance of the wire inside the kidney and dilated system, dilated upper pole, you can coil it in the upper pole. Here, always make sure that the incision is enough for the sheath. Here, I'm using conventional, maybe Tariq Amin will be angry with me. I'm using conventional PCNL 30 French, so I need to have a generous 1 centimeter incision so that I don't struggle. If the incision of the skin is small, you struggle when you introduce the sheath. After that, I use the dilator, was called 810 French dilator. Okay, and it is very handy. You can use it in supine and prone. Always make sure that you are holding your wire yourself and the assistant give you the dilators, because I noticed in supine PCNL that easily the guide wire I slipped compared to the prone. Okay, here I introduce the dilator and make sure is it going inside the collecting system under fluoroscopy. You introduce till you feel 3 pops. I call it the fascia, the dorsolumbar fascia, then the capsule, then the collecting system. If you feel the 3 pops, then you are inside the collecting system, even without looking at the X-ray. But always we look at the X-ray to make sure that we are inside the collecting system. Once we are inside the collecting system, I introduce the sheath, the 10 French sheath, which accommodate 2 guide wires. I always use safety guide wire and working guide wire, and it is a better practice. Sometimes when I do mini PERC or like single step dilatation, I use 1 guide wire only. But most of my practice here is doing, and this is our practice in HMC, and I find it very, very safe, and it will save you in many, many occasions. If you use 2 guide wires, okay, when 1 guide wire slipped or it has a kink, then you can use the other guide wire. Okay. So here, when you have we introduce the sheath, you make sure it is inside the collecting system. And one of the signs, when you remove the dilator, also you see urine is coming. You see the urine coming through the track itself, the sheath itself. When you see urine, you are inside the collecting system. Don't need to push more. Okay. If you see blood, you mean you need to advance it a little more or pull it a little more. This means you are not in the collecting system. Here you can see urine. This is the stiff guide wire, which I use it as a working guide wire. We use this M-Plat super stiff in HMC, which is very good for dilation, and it will support the balloon, and it will support also the sheath. The problem mentioned earlier that the kidney is mobile in supine PCNL. So be careful when you push the balloon. Don't push it. If you really push it in a hard way, you will push the kidney too much medial, and sometimes it make your track very long. The track is longer in supine PCNL, And always make sure that you have a longer sheath and the longer nephroscope on the table beside you, because you might need them. In this patient, we did not really needed longer sheath or longer nephroscope. We use the conventional one, as you can see here. This is the sheath and the balloon together. Okay, sometimes you go with the balloon, then you go out and go dilators, but we prefer to do balloon dilatation and directly put the sheath over it. You see there is a dot, radio-opaque dot in the balloon, and this 1 centimeter distal to the dot, there is a distance. So make sure that the dot just reaching the infundibulum. When you reach with the dot, the infundibulum of the calyx, this is your maximum point. Don't go further in, because you might end up with a tear in the renal pelvis. You can see the dot just entering the infundibulum, and this is your limit for dilatation. That's where you have to stop and then inflate the balloon. We use Lavin syringe in HMC, and this balloon is designed to have a pressure up to 22 atmosphere. I prefer to go with a gradual inflation rather than directly inflate, and also look at the pressure. But once you really need to put the sheath, you should have the optimum pressure. You should have the maximum pressure, 20, 22, so that the balloon will be hard enough to support the sheath. And you can see I'm passing the infundibulum a little bit, which is okay. Still the renal pelvis is here. I did not reach the renal pelvis. I'm still inside the calyx. Then you have some minimal banana effect, what is called, of the balloon. But if the pressure is optimum, 20, 22, and you use some lubricant, usually most of the time, you will succeed to pass the sheath over the balloon. We use some lubrication, then we pass the sheath over the balloon. Once the sheath under fluoroscopy reach in, then you are in, then you are ready to introduce your nephroscope. Here, luckily, the patient is thin with low BMI, so the track was not that long, and we use ordinary sheath. And the nephroscope, we use 26 French in this procedure. You can see here the stone is straightforward stone, not a difficult stone, which is ideal for a video presentation. We have much more difficult cases, but this is just for the teaching purpose. We choose an ideal case. This stone is very visible and very feasible to be fragmented and removed. We use ultrasound with suction device, and it is very handy that you introduce the ultrasound. It has the energy to fragment and suck at the same times. And one of the tips and tricks in supine, when you end up with some fragments go into the ureter, before you go to combined approach, which can be done in this procedure, you can use the catheter tip and ask your assistant to flush some saline, and the fragments you will see will be pushed up. But don't overdo it, because you will flush the fragments to the upper calyx. So sometimes if I feel fragments are going to the UPJ or inside the ureter, I ask the assistant to push some saline through the ureter, and it will, most of the times, these fragments, you will see it in the renal pelvis. We fragments, then we remove most of it. You can see the catheter tip here coming from the UPJ, and we remove the fragments with forceps. Here we use in our drape this nylon, because you don't want to end up with the floods. And with this nylon, many times we end up with the floods in the theater, and anesthetist and nursing will be angry with you. So don't overuse water. Try to use it in a proper way. You can see here the renal pelvis is clear. I push the catheter a little bit inside by my assistant, and the flush again, and make sure nothing inside the ureter. If nothing inside the ureter, no need to go by retrograde. I do nephrostogram after procedure to make sure no extravasation. Alhamdulillah, here I can't see any significant extravasation. Here the calyces, and here the UPJ, and this is our catheter. Then we use the stent routinely. I use a stent routinely after PNL, because PNL is somehow invasive procedure. You go through the collecting system. So I recommend using double J stent. In most of our cases, we stent, and it is easy. You can keep the stent 5 days and bring him in the clinic, or 1 week, and just remove it with a flexible cystoscope in the clinic. Here, what is good in the supine PCNL, you can put the stent under vision, so you save some X-ray. because it's an X-ray procedure. So try to minimize the X-ray as much as you can. Here the guide wire is inserted under vision and it's seen in the nephroscope. Then after the guide wire insertion, you can just insert the stent in retrograde fashion. If you feel you can remove it with a thread for 5 days, it's okay. Or if you want to keep it another 10 to 15 days, then just to keep it without the string, because it will be very annoying to the patient if you leave the string longer than 3 to 5 days. Here the assistant is introducing the double J stent, and we don't use any X-ray. We just look at the kidney and wait for the stent. With my nephroscope, I can see the guide wire, and this is the upper calyx, and wait for the stent till inserted, and you will see it will come in a few seconds. Once you see the stent here, you push it to the upper calyx as much as you can to reduce stent irritation. And then in the bladder level, you need one X-ray to make sure that the lower coil is in proper position. And once you see that it's in position, the other question is whether to put a tube or tubeless PCNL. This is a big question. I tried some tubeless PCNLs, but we end up with some complications. I do it in selective procedure. I do say the tubeless procedures. And as John Denstead said, if you look at the track and find some bleeding, it's better to leave a hemostat. So I leave like some hemostat for 48 hours most of the time. It should be enough. And when you see a clear output coming at the end of PCNL, first of all, say thanks God, Alhamdulillah, that you perform the procedure without significant bleeding. You fix your tube, the stent is inside, and then you just can shift the patient to recovery in a good shape. Thank you for listening, and thanks for all the organizers, okay, especially the support from Qatari Medical Association. Thanks for our colleagues from Yemen, from Iraq, and whoever attended this meeting. Thank you very much.
Thank you, Dr. Ammar.
Thank you, Dr. Ammar. It was a great video, actually.
Thank you very much. Thanks.
It was great, and we feel that we are inside the theater room.
Okay.
So it was from access to exit. Now we have a poll. We can, and after that we will start asking the questions of the attendees. We have some questions. So please, now we need the poll. Yes, now it's appear, it is in the screen. Do you perform combined supine PCNL and flexible ureteroscopy, ECIRS? Okay, so only 12% who are doing combined supine PCNL and flexible ureteroscopy. The majority, 72, not doing. Dr. Abdullah Al-Adimi.
Okay.
Dr.
Assalamu alaikum.
Al-Adimi, consultant of urology, and he's the main moderator in this webinar. You can start, please.
Okay. Assalamu alaikum. Thank you, Dr. Murshid. Thank you, Dr. Ammar and Dr. Tariq for informative and valuable presentation. We can open the questions. I want to start with Dr. Murshid. Dr. Murshid, you know, we're facing in Yemen complex and hard and staghorn stones. And sometimes need multiple puncture, sometimes need upper ball axis, need good manipulation for rigid nephroscope and good distinction inside the kidney. What's your opinion in these conditions? Still preferred supine?
Yes, in my opinion, supine also, supine you can do also multiple tracts, but with the advancement of the endoscopic combined surgery, you can do the one tract and the rest do it from downward flexible. Even if you have a big stone, you can fragment it and bring it as big fragments. Because no need to remove through the catheter, you can just remove from the calyx that you cannot reach and bring to the renal pelvis, and then you can remove them with the nephroscope. But I think it is a matter of habit. It is difficult to change from habit that people are doing, and mainly they are afraid from the colonic injury or other organ injury. But with the time, they can have experience, and for the upper calyx also, it is easier to approach the upper calyx from within under supine position, easier than in prone position. And if we follow the role of Dr. Sanjay to puncture, if you have multiple stones, and to puncture the mid calyx, you can reach from the same tract the lower and the upper calyx. I would like to mention the comment of Dr. Gusty when I asked him when he was here, what about the staghorn stones? In one of his answers, he told the staghorn stone better to do it in prone. And in other answer, he told he is doing also in supine. From my experience, I am doing some cases, I am doing in prone, some in supine. In the last few cases, if you saw my videos, I did staghorn stones in supine, and I could reach either with combined or alone. Alone, if you have dilated system, you can move easily inside the kidney without causing tears in the infundibulum.
Thank you. Dr. Shukri, can you read some questions?
Yes, and before that, I want to ask Dr. Pal. I know, Dr. Pal, you are doing conventional PCNL in a prone position. So we want to hear from you what's your opinion about the supine PCNL and mini?
Dr. Pal, especially for upper ball axis. Dr. Pal is a pioneer for upper ball axis.
See, in fact, I have got labeled that I am doing only a standard PCNL. It is not so. I am doing every type of PCNL, mini as well as ultra mini. But everything depends upon the stone characteristics, its location, as well as what I always remember is that I don't have to give torque to the kidney renal parenchyma. All our instruments, nephroscopes, are straight instruments, straight stainless steel instruments. When you are doing a supine PCNL, obviously you can enter the kidney through its lateral border only because of the anatomical location. If you have to enter right from below or right from above, and that gives you a greater access to see the whole kidney from inside, then you have to place the patient prone, because prone position gives you a very wide area from sides as well as from both the superior and inferior pole. Vertically you can go in. So everything depends upon the proper planning in the beginning, and then you can put the patient supine or prone. For secondary stones or maybe small stones which are in the calyx, I always use saline push technique. If you master the art of puncturing, you can puncture from one calyx and then flush with the saline. So that particular stone will come in front of you, and there is no need to do a ECIRS and such other ancillary procedures. So that is the way I always plan and do either supine or definitely supine are only about 10 to 15%. Most of my cases are prone. Size, my standard size now has become more or less 22 French, 21 or 22 French. Sometimes 30 French and a standard PCNL. I hope I have answered all the questions or what all doubts you had about my.
Thank you, Dr. Pal. Thank you so much. Dr. Tariq, in your presentation, you offer us various sizes and also types of mini PCNL. What's your preference? What are you doing daily?
This is a good question. Actually, you know, as Dr. Pal mentioned, and it is always said that each patient is tailored his treatment accordingly and planned preoperatively. So in big stones, as I mentioned, more than 3 centimeters, I go for conventional or standard PCNL. And according to the location and the characteristics of the stone, accordingly, I plan my procedure. For stones between 2 to 3 centimeters, I would prefer less size. I would go for miniaturized PCNL with an 18 French sheath, while less than 2 centimeters, I would go for the SMP. It offers me a very good outcome with the less morbidity. The newly launched, the Cleopatra, again, it's very nice. We're evaluating different sizes. It is very fast enhanced with the suction, with the low intrarenal pressure. But again, I'm not going for beyond 3 centimeters with a miniaturized PCNL. Regarding the position, most of the time we prefer supine position. Previously, we were doing all prone position. Still, we are doing some cases in a prone position, as Dr. Pal mentioned, but we're in a reversed percentage right now. Most of our cases are supine. Regarding the thing is, you know, the bigger size allows you using the pneumatic and the ultrasound lithotripsy, which is much faster with good visualization. The Cleopatra allows pneumatic lithotripsy, which is equivalent to the 18 French, especially that there is Cleopatra with 18 French, which is again enhancing the suctioning and the retrieval of the stone fragments. Laser, we tried the different lasers, holmium and thulium. Thulium is still under evaluation. It is promising, but still needs some time for good RCTs and experience with the thulium fiber laser.
So again, Dr. Tariq, a question from Yemen. If I want to buy only one for mini, I mean nephroscope for mini PCNL,
yeah,
which one is the most cost effective? See,
I would go with like Dr. Sanjay Kaji with the 18 French, which is midway. One of the slides was comparing a very nice study comparing between conventional versus mini and ultra mini. See, the mini PCNL is still midway between different variant sizes, while the conventional is still, it's considered the gold standard. You know, mini PCNL, I would, for small sizes stones with less morbidity, I would go for the 18 French, especially with the Cleopatra sheath suction, yeah. If I'm buying this.
Thank you, Dr.
Of course, you will need the conventional beside you sometimes.
Yeah, so it is, you recommend 18 French.
18 French.
The most cost effective.
Yeah.
Okay.
Okay.
This question,
Dr. Shukri, Dr. Ammar. Yes, I want some for Dr. Ammar. Dr. Ammar, what's your opinion about supine and congenital anomalies, either in the kidney like horseshoe or malrotation, and if you have some deformity in the spine like kyphosis and scoliosis? What's your opinion about supine with these conditions?
That's a good question, Dr. Adimi. Okay, actually, the recommendation of the Endo Society in congenital anomaly, in anomalous kidney, most of the times you have the kidney facing posterior. I mean, the calyces are facing posteriorly and the renal pelvis facing anteriorly. So in supine PCNL, you know, we go lateral. So it is not very convenient. I don't recommend supine PCNL where you have anomaly and malrotation of the kidney. Okay. One of the ways of doing anomalous kidney is to go with a flexible. If you can achieve it with a flexible, it would be much more convenient. But if you have a larger size stone and there is a degree of malrotation, as when you see in horseshoe kidney and other anomalies, then you go with the prone rather than supine. In pelvic kidney, we either go for laparoscopic approach, where you go under vision and just make sure the viscera is away from you, no bowel in your way, and do the puncture under vision. Or there is a very nice way published by Desire where he used the ultrasound probe and push the viscera away till you see the kidney in the ultrasound, the pelvic kidney, then you puncture it. So in the pelvic kidney, it's neither supine nor prone. It is direct puncture, depending on the position of the kidney. In other anomalies, I recommend a prone rather than supine because it's very difficult to go lateral.
Thank you. Dr. Paul, do you have add something?
See, if the patient has scoliosis and this kidney which you are going to operate upon on the convex side, so always the principle is to make the shortest possible track. In supine, in a scoliosis patient, the kidney on the convex, where the convexity is there, that side the kidney becomes very close in supine position. So I will be doing a supine PCNL on the convex side, but at the same time concavity side, it will be the prone PCNL, which will be much closer because I have to make a short straight track up to the stone. Otherwise, if you see the overall versatility, then the prone gives you a overall versatility wherever, whichever way you want to enter, a unascended kidney or a crossed renal ectopia or malrotated kidneys, horseshoe kidneys. Prone gives you a very wide range of access. Even if while doing a case, if the stone migrates from one calyx to the other calyx, and if the patient is prone, it is much comfortable. Then you can go from any ancillary track you can make and you can do the procedure. So definitely, as Dr. Ammar has said, the prone gives you a wider access, and most of these cases can be done with the prone position.
Dr. Murshid, can you give us some your experience for pelvic kidney stone, congenital anomalies, and assistant by laparoscopy?
Dr. Murshid, please unmute your mic.
Yes, unmute. Sorry. Yes, actually, I have done one case in my previous work in Wakra Hospital, and I did it laparoscopically assisted. So can go with 1 or 2 ports maximum. Some 2 ports if you need to move the bowels from the tract, from the way of the needle, and we did it nicely. And you have to. It is actually easy because you will not, you will do the puncture under the vision, but you need some experience also in laparoscopy. Actually, our mentors in Hungary, they have published in the 90s, 15 cases, laparoscopically assisted PCNL. So I think this is if the stone is large, but if it is not large, you can do it with flexible. Flexible is the best choice.
Thank you, Dr. Morshid. Dr. Khalid Al-Kuhlani, I think you have a question.
Yes, thank you very much. Actually, we are very happy with this nice discussion and this valuable webinar. I had two questions, but one already has been given by Dr. Adimi and answered by Dr. Ammar about the anomalous and horseshoes, kidneys, and tips and tricks and so on. So I will move to the other question. I don't know if this was have been mentioned during the lectures. As I feel from the opinions of the experts with us, Dr. Bal, and even Dr. Murshid said that Dr. Gusty, I think, when they asked him about his preference for staghorn stones, he said preferred prone position. Then he said, I can do it also in supine. So I feel that, that there is preference more towards prone PCNL in difficult situations, in staghorn, complex stones, and so on. My question is for you, from your experience or from your reading, is there any rate of conversion from supine to prone or from prone to supine, so that we start one case in this way, but we find, oh, okay, we have to change it or to convert to the other technique, which maybe will be better for the patient. Is there any rate of such conversion or not? Thank you very much. Hello?
Yes.
Dr.
Hello. Hello.
Yes, Dr. Paul.
Is the question is the question is directed to me?
Yeah.
Yes.
Yes, it's an excellent question. It is an excellent question which has been raised in many webinars or in conferences in supine versus prone. And I can definitely see, I have witnessed two cases being done in supine position where they were converted to prone. And because of a greater versatility of the prone position. But I have not seen a prone getting converted into supine. So again, because of my experience with the prone is better, is more, I feel in all difficult situations, prone definitely has an edge, should be practiced. But in routine positions, routine small stones less than 3 centimeter, even supine is good. That is my opinion.
Thank you.
I agree with our friend, great PCNL surgeon, Endurology surgeon, Dr. Pal. We met with him in several conferences and here in Qatar also. So yeah, I didn't convert, but I think from the beginning we should choose because it is, if you are already there in with the nephroscope, it is difficult to do conversion. You can just, if you have difficulties in the puncture, use all the facilities that you have. For example, one time we had difficult access with X-ray, so we asked for ultrasound puncture. And if you have difficulties to continue, you can stop it and come for next next session, or you can do also combined with flexible.
Thank you, Dr. Morshid. Dr. Haidar.
Dr. Shukri, can I comment on this?
Yes,
okay.
after that, after your comment, we want Dr. Haidar to
sure.
just to talk about the experience in Iraq about supine and mini.
That will be very, very good. Just a few seconds. For the conversion rate, I think literature is very, very rare, as Dr. Pal and Murshid said. And I think if you study the imaging properly and you design your puncture, most of the times you can say I'm going either supine or prone. Conversion inside the theater from prone to supine is not really feasible, is not a good thing. You can change the calyx, you can go with the help of the endoscope from below, but conversion I don't recommend it, and is not really published in the literature. There is no conversion rate. If you review, there is no conversion rate from prone to supine or supine to prone. Okay, thank you. And Dr. Haidar now, please.
May I?
Thank you, Doctor. Thank you, Dr. Tariq. Thank you, Dr. Ammar. Thank you, Dr. Shukri. Thank you, Dr. Abdullah Naimi and Dr. Khalid Al-Kahlani. Our experience in Iraq started in 1998. We started in first PCNL in Iraq. Then stopped till 2003 because a conflict in Iraq. You know the conflict in Iraq. And I cannot start videos because the host cannot permit to me. Can you permit, please, to me? Our experience after 2003 started in 2008. You know, the stone in the Middle East, our stone is very hard, like Yemen stone. All patients come to us complaining from, at the end stage, complex stone, staghorn stone. Not come to us as a small stone, less than 1 centimeter. We have not, rarely come to us complaining from pain, like lower pole stone and mandibular stones. So our experience started in 2008 as prone positions and use fluoroscope. Then we use our modality, more modality for piano, started in 2010. And some modality scope and using one port and complete all the clearance of the stone with the flexible nephroscope and laser. We don't have experience in use mixed modality, flexible URS and nephroscope. Now we started in 2019. We start combination between flexible URS and nephroscope from up. About the supine and the prone position. About Iraq, 80% of surgeons use prone positions and only 20% use supine positions. You know, as Mr. Skpal says, our duty for renal stone is to do our aim to clear all stone from the kidney, whatever the position, is it supine or prone? Because our patients sometimes come obese patients. So we use not supine, not prone, sometimes use lateral positions and semilateral positions. So according to the size of the stone, according to the build of the patients, according to the congenital abnormality like kyphoscoliosis and other things. Our experience is prone positions, 80%. Supine position, we use it and well done in it. And 80% and 20% from surgeon. We use ultrasound in lateral positions and well experienced in it. And I till now I finished from 2008 till now about 7,000 cases, 350. In pros about 6,500, and in lateral position, especially in obese patients and kyphoscoliosis, about 500, and the rest are semilateral and supine. Thank you. This is our experience in Iraq.
Thank you.
And just one asking about Dr. Ammar about, he says a posterior axillary line, and we go lateral to the posterior axillary line. What about in the obese patients? Is it the same elevation and some tilting in the supine position, or elevation more?
Yes, thank you for the question, Dr. Haidar. No, even in obese patient, you don't need to tilt more, but you review the CT properly before the supine PCNL, and make sure that there is no colon interposition really between you and the kidney. Okay, if you feel that there is a colonic interposition, and if it is going a little bit posteriorly, then at this stage, I don't recommend the supine PCNL. And sometimes not only the colon, and we have some cases of hepatomegaly in the right kidney, and you see the liver edge is coming in your way, in the kidney and your brain. In the CT scan, if you look at it properly, you can say where is the colon and where is the kidney. Now the imaging is very nice, and you can rotate, and you can go 3Ds. You can see all the viscera before the PCNL. So you have no excuse, okay? Most of the times the tilt is 20 degrees. If you tilt more, the problem, your puncture will be much more difficult. More tilt, more difficulty. The ideal tilt, if there is no colon or visceral interposition, is 20 degrees. And then even in obese patient, but to try to really make the line properly, the posterior axillary line, when you position the patient, draw the posterior axillary line properly, considering the fat, then you can do. But I prefer with obese patients, longer sheath and longer nephroscope. You will face a longer track. That's the main recommendation.
Thank you, Dr. Ammar. I ask Dr. Tariq.
Yes.
How many regarding mini PCNL, how many access you can did to the kidney if there is a multiple calyceal stone in the middle calyx and in the upper calyx and in the lower calyx, small stones? How many access you can did, Dr. Tariq?
Yeah. Very nice. Actually, for us, prefer to go beyond 2 or 3 more maximum. Actually, in literature, beyond 3 more complications, and even beyond more than 1 axis, more complications are encountered. But there are other alternatives that we can do to avoid the axis. Like Dr. Pal, as he mentioned, he can just puncture the calyx, push fluid saline, and push the stone towards the other track. Otherwise, we use endoscopic and intrarenal surgery with a flexible ureteroscope and reach the other stone and get it to pass the ball to the other track. So the idea is we're trying to avoid as much as possible the multi-tracks. And even with mini PCNL, it is having more morbidity. Of course, it's less than the conventional, but again, it's having complications. So as much as possible to reduce it, especially with endoscopic combined. Just a hint regarding the position, your previous question to Dr. Ammar, I would just add, I totally agree with Dr. Ammar, just the tick, as he mentioned, to plan the line before proceeding with the position. The posterior axillary line, and usually we just put plasters and push the redundant skin to the other side, so as the line would be accurate. And regarding the retrorenal colon, we usually scan at least by an ultrasound to make sure that there is no retrorenal colon before we proceed.
Dr. Tariq, from first lecture, did you trust in this person 2% retrorenal colon in supine position and 10% in prone position? Do you trust in this person?
See, I'll tell you one thing. Actually,
really, this is a nice question.
It's a very nice question. Let me tell you, avoiding the percentages, 2 things. The first of all, when we do a CT scan, let me say more than 99% of our CT scans are in supine position, not in prone. If you really need to know to plan your prone PCNL, you need to do the CT scan in prone position, and so you can see the retrorenal colon or not. Actually, most of our CT scans, we don't see a retrorenal colon, and even in the semi-lateral position. However, I myself encountered the retrorenal colon when once I positioned the patient in a supine position, or the same position that Dr. Ammar presented. And because I routinely perform ultrasound before I proceed, I saw the colon before I puncture, and I redraw the line again, avoiding the colon. I mentioned here is the colon, and totally avoided completely for this issue. That's why it's much safer to perform an ultrasound before proceeding.
Yes, thank you, Dr. Tariq.
Dr. Tariq, I would just, can I make one comment, Dr. Tariq?
Yes. Doctor, yes, please. Yes, please.
Dr. Tariq, when we do a CT scan, and then when we do the procedure, usually there is a gap of a day or two in between. We don't do a CT scan on the same day or same time. And when we don't operate under CT scan guidance, colon is a mobile organ. Colon keeps moving from here to there, and therefore you cannot rely 100% on the colonic position in the CT scan, which was taken 3 days ago or 4 days ago before the surgery. So you have to be definitely extremely careful, either with the use of ultrasound or with the fluoroscopy, and with your advancing needle, you have to keep checking the gas shadow in the colon that it does not come on your way. Even if it was not there in the CT scan in the retrorenal position, on table, it might be there. Secondly, in obese patients, if you see the distribution of fat and obesity, it is more on the anterior abdominal wall, anterior to the posterior axillary line. And as Dr. Ammar has very rightly pointed out, that nowadays CTs are very good. In the preoperative planning, you should see the least distance from skin to stone distance from the posterior axillary line on the CT scan. If the distance from there is shorter, you can do a supine PCNL. But even in obese patient, if you tilt the patient little laterally, and then if you go more posterior to the posterior axillary line, and then puncture, there will be a shorter track. Track should be shorter in obese patients, because if you lose the track, and if the kidney is very mobile in obese patients, it's quite mobile, then it will be difficult to find the track and do the procedure completely. So these points, preoperative planning is very important. Don't depend only on the preoperative CT scan that the colon is definitely not retrorenal. Regarding on table, when you experience even retrorenal colons which were seen in the CT scan will not be there retrorenal when you do the position of the patient. So that is just an example that it is there, it may be there, it may not be there. You have to be careful in each and every case to avoid puncture through the colon. That is a must.
You're right. That's why I made it as a routine to scan it by ultrasound after the positioning. You're right.
Okay, exactly. Dr. Shukri, question from attendants.
Yes, there is a lot of questions from attendants. So we can start with already repeated question about ultrasound guidance puncture. This is for Dr. Morshid. Are you doing usually ultrasound? I think the question he needs to know, it is just only ultrasound or combined with fluoroscopy, and this in supine position. In every case, you are doing supine. You are doing supine PCNL. Are you using the ultrasound, or in some cases, and what is the indication to use the ultrasound guidance?
Yes, it depends on the experience of the surgeon. Depends for those who worked on prone, what they used to do. They are using in prone simple fluoroscopy. They can do it nicely. Myself, when I started my first PCNL, I started in fluoroscopy and in vertical in 90 degree, in 0 degree. So I never tilt the 30 degree. I'm doing the puncture in monoplanar axis, and by experience you can feel the track. You can see the movement of the kidney. You can see the retraction of the calyx. And as Dr. Pal mentioned, always you have to observe the shadow of the colon, always, always. Even in fluoroscopy, you can see it. Even if it is not, if there is no in situ retrorenal colon, but if the bowel is distended, the colon is distended, it can be in your tract. That's why you can see that the colon also is moving. So you can come back and go one step back, I mean posteriorly. But ultrasound depends on the for example, in some places in US, in some doctors in France, they are using the ultrasound guidance for the puncture. But what I can suggest for those who are having in their theater ultrasound and fluoroscopy, they can use actually both. So you can use the ultrasound to show your, to see that there is no colon in your way, and also to target the calyx that you want. And when you reach the kidney, you can press at the same time the fluoroscopy, and you can adjust it a few millimeter, and you can also with from the first trial you can do the puncture. So the best is to do both ultrasound and fluoroscopy at the same time.
And this is also going with the idea of Dr. Pal that the colon is a mobile, and so you cannot judge from the CT scan done 2 weeks ago or sometimes 1 month ago. So it will, the ultrasound guidance, it will be crucial in these cases. We have question from Dr. Muhammad Babakri. He is the Vice President of Urology Association in Yemen, and also he is Vice Dean of Faculty of Medicine in Aden. So please, Dr. Muhammad, you can unmute your mic. Dr. Muhammad Babakri. Okay, maybe he's not ready yet. There is a question.
Do you hear me, Dr. Shukri?
Okay, yes, you can. We hear you.
Assalamu alaikum.
Salam.
Thank you very much for this nice, informative webinar. Actually, my question was about the of the balance. What about their experience in using ultrasound guided puncture? And already Dr. Murshid mentioned something about that. The other questions, when they did a supine PCNL, usually the collecting system is dependent. What are the rate of bleeding? Is it more during supine or the same as in prone position? And is it difficult sometimes in this collapse dependent system that you can't reach all the desired because of the less pressure inside the collecting system? I need to hear about this, and thank you very much.
Thank you, Dr. Muhammad.
Yes.
So that
I would answer. Yes, in my opinion, if you have possibility to have a closed balloon, just use it. And otherwise, you have to go to continue with contrast mixed with methylene blue. See the ureteric beside the ureteric catheter. To have a good puncture, your system should be targeted calyx also. With the these tips and tricks, you can find them there inside the theater, as I mentioned, by giving either continuous contrast, or if you have occlusive balloon, you can fill it and it will not go down. It will not be empty.
Thank you, Dr.
And regarding it depends on the practice and the experience.
Thank you. Question from attendants about to all our speakers. Do you have any experience pediatric PCNL?
For us, we don't do pediatrics.
Dr. Murshid,
I
Dr.
have
Tariq.
experience from Yemen and Hungary, but here in Qatar, the role is different. And the children below 14 are going to the pediatric, and they have also in the pediatric surgery, they have pediatric urologist also. So here we don't do, but we had experience on endemic bladder stones, on PCNL. We did even bilateral PCNL in Hungary, and we published it in British Journal of Urology. It was in old time, we did it with the standard nephroscope, but now with the miniaturization of the scopes, we can do it with the mini PCNL, but we don't have the privilege here. We don't do it.
Dr. Paul, please. You prefer?
Yeah, I have fair.
I
have fair experience of pediatric PCNL.
You prefer for pediatric case supine or prone?
Prone, always prone, because the colonic injuries, because pediatric, there is a very less Girota's fascia. Kidneys are very mobile. And if they go much more medial, and if the intestines and colon, they come in between, it will be difficult to manage them. So I always do all my pediatric cases prone, always in prone position. And secondly, the most important, and I think the only important thing in pediatric is to remember that these children, they cannot tolerate much blood loss. So you have to be very careful. If you feel the bleeding is more, you should stage the procedure. In between, you can leave the procedure, because my youngest child was 10 months old, fortunately done in single sitting, because there was not much bleeding. But only precaution you must take is bleeding should not be more, and you can stage the procedure and do in prone. As otherwise, you will not find any difference in procedure part, whether it is a supine or whether it is pediatric population or an adult population.
Dr. Bal, do you have any? Dr. Bal, do you have any limitation about the age in the children?
No, youngest was 10 months old with a staghorn. So I had to do that case. Otherwise, there is no limitation. You can do any age if it is becoming stone is causing obstruction to the kidney and obstructive nephropathy. Because in the younger children, the kidneys are developing faster. And you have to be very careful that the kidneys, they develop optimum. So you have to relieve the obstruction and infection as early as possible. So there is absolutely no problem. Rather, I am very critical about doing RIRS in children, because the limiting factor is the size of urethra and size of ureter. If you do RIRS with a big ureter with a flexi-nephroscope of 9 French in a pediatric population, you are likely to cause a urethral stricture, which will be a lifetime agony for the child. Rather than doing a PCNL, which is a smooth surgery, the only precaution is blood loss. Regarding distension of calyces, I will always prefer distending the calyces with saline, not with contrast. Because if you use more contrast, and if by chance there is pharyngeal rupture and extravasation takes place, then you cannot identify the residual stones, and procedure becomes very complicated and fuzzy. So it is always better to go on distending normally with normal saline. Whether the patient is dehydrated, supine or prone, always better to keep the pelvic calyceal system fairly distended when you are making the track and passing the guide wire, so that good space gets created between the stone and the pelvic calyceal system for a proper placement of the guide wire. So gently keep it distended. Your assistant should not be over enthusiastic of going on pushing the saline, otherwise there will be perforation of the fornix and then the extravasation will start. So these precautions you have to take. Sorry, I took a long time.
No, thank you, Dr. Pal. Thank
Good
you.
information.
There is one question from our respected attendee, from Dr. Hussam Al-Hams from Palestine. His question about the parenchymal thickness, if it is less than 1 centimeter or 1 centimeter or less, is it safe and easy to do PCNL? This is the question for Dr. Ammar.
Yes, thank you. That's actually is a very good question, and we're happy to hear that we have colleagues from Palestine. Okay, the parenchymal thickness is not really a contraindication for PCNL, but it is a precaution. And the two precautions here you have. These thin parenchyma, they can tear easily. You can fairly easy puncture the thin parenchyma because most of the time you see a dilated system and you can enter the system. But be careful during manipulation. The shearing force can easily tear the parenchyma and cause more bleeding. And when you remove the nephrostomy tube, I never recommend a tubeless PCNL in a thin parenchyma. Always leave a stent and nephrostomy tube, and be careful, you might have a longer time for the fistula to heal, especially if the patient is thin. When you remove the nephrostomy tube, you'll have a longer duration of leakage of urine if you don't have a major leak. And there is a risk of bleeding there. If you don't have a support of good angioembolization system in your hospital, be careful with these cases, because risk of bleeding is there. But it's not a contraindication. You can do it in a thin parenchyma. 10 millimeter parenchyma, you can fairly puncture and dilate. But take care, don't use the shearing force and leave a tube. Don't do tubeless.
Thank you, Dr. Ammar.
Thank you.
Another question from Dr. Majd Al-Riashi. For Dr. Tariq, he asking for stone less than 2 centimeter. What you are preference, RIRS or super mini PCNL?
This is a very good question. Actually, to answer this, I would prefer rather to say a 2 centimeter stone, we would say by volume. So if we speak about the 2 centimeter stone as a 4 centimeter cube stone, it is very exhausting to do flexible ureteroscopy for such a stone, especially if it is in the lower calyx. And frankly speaking, if you want to reach a stone clearance, complete stone clearance, it's very difficult if it is 4 centimeter cube in the lower calyx again, without any residuals. Would not let us define as stone clearance as a complete clearance, not a 4 millimeter residual stones. So for stones less than 1.7, let us say 1.7 centimeter cube, I would go for flexible ureteroscope, especially if it is not in the lower calyx, while beyond 1.7 centimeter cube, I would go for mini PCNL rather than flexible.
Thank you, Dr. Tariq. Dr. Bal, still with us?
But he's mute. He should unmute.
Yeah, he is now.
Dr. Bal? He closed his microphone. Mic. Dr. Bal?
Yes, please.
I want to ask you about your PCNL without assistant retrograde.
Sorry, I had unmuted. Sorry, I could not listen to the question.
Your experience and your opinion about integrate PCNL without assistant retrograde.
Integrate PCNL.
Yeah, immediately PCNL, integrate PCNL without any retrograde assistant by bilography.
No, it should never be. I will always prefer to have a ureteric catheter in the pelvic ileal system before any PCNL. If the retrograde catheter is not going in, I will take all the help of a ureteroscope or anything to see that there is a distal patency. If you do without checking for distal patency and make a puncture in the kidney, it will continuously leak. if there is no distal, if there is no way for urine to go down, where it will go if you puncture the kidney? So I have to have a retrograde access to the pelvic ileal system with the help of a ureteric catheter. Sometimes the pelvis is so much inflamed and edematous, it becomes difficult to find the PUJ. So if the ureteric catheter is inside the PUJ, at least you can identify and put a double J stent. As Dr. Amar pointed out, he always puts a double J stent in each and every case. I also do so. In each case, I put a double J stent. So there has to be a distal patency. Only without a support from retrograde, I will not touch, I will not do a PCNL at all.
Okay, thank you. Dr. Tariq, you mentioned when you compare between mini-PERC and standard PCNL, you say the stone-free rate is equal if the stone less than 2 centimeters. But if the stone more than 2 centimeters, this was facing in our country and also in Iraq and Yemen. We have two comments. One, if the stone more than 2 centimeters, it is still the stone-free rate same, mini-PERC with standard, this number one. Number two, what about the duration of the operation? If I use the mini-PERC, if the stone more than 2 centimeters, I will use the anesthesia long time with the patient with mini-PERC. It is safe for patient also? What your opinion about this condition?
Is a very nice
Prepare the
question.
mini-PERC?
Yeah, actually, this as per the studies, actually, I was showing the literature, what it says. As per personal experience, again, I would recommend mentioning the volume rather than the stone size itself, 2 centimeters, the maximum diameter. But let us say beyond from 2 to 3 centimeters, or 2 to 2.5, let us say 8 centimeter cube, I can still do the mini PCNL with 18 French sheath. But beyond this, no, I would go for the standard. And again, the more the bore caliber, the better for such stones, easier and faster. The problem is not only for the duration of the procedure, it's not only for anesthesia, it's again increasing the risk of infection. And the stone clearance, again, this is another problem. And the visualization. All of these are problems with the smaller calibers with such big stones. So beyond 8 centimeter cube, I wouldn't do any mini PCNL.
Dr. Nabil, want to put some question, Dr. Nabil?
Yes, Dr. Ademi, thank you very much. Assalamu alaikum. This good opportunity to meet you in this informative webinar. Thank you for the moderator, thank you for the speaker, and for the organizer committee. Actually, my question during the video by Dr. Ammar, thankfully it is a very nice presentation, and I know about the access, the puncture. There is 3 ways for the puncture actually. There is a gradual descent, either in monoplanar or biplanar. There is triangulation, and there is bullseye technique. And I would like if we can highlight this bullseye technique and triangulation in other webinar. It would be very nice for the subject in the next webinar. Regarding the gradual descent technique, using this monoplanar. Actually, I saw the method for Dr. Ammar. He went directly through the monoplanar, and if there is no any drainage of the clear urine, he turned to the 30 degree for the depth of the puncture to the tip of the fornix. If we can combine both, I mean, for the monoplanar, the capsule of the kidney for the direction of the axis, then to turn to the 30 degree for the depth, I mean, to be usual. My question is, what's the expert opinion regarding this one? To depend mainly on the monoplanar, it's okay, or the best way to do biplanar depth and direction in the same axis or getting axis? Thank you very much.
Thank you, Dr. Nabil, for your question. And there is old saying, they said there are many ways to skin the cat. Okay, there are many ways to enter the kidney, I would say. And in this era, I fight with Tariq, I mean my friend, about the size. I feel he is reducing the size every day, and he will go with, I don't know, one French puncture to take out the stone. I do mini PCNL, but also I do conventional. And for puncture, I prefer the triangulation, and I find it like very easy, and you don't need much effort. You have two planes. When you design your puncture that you reach the calyx, then you need to know the depth, which is very easy. It will take another 2 minutes to triangulate and see whether you are anterior or posterior, and follow the needle. This is my rule. But nevertheless, there are many ways. As Dr. Murshid said he's do monoplanar, and he has experience with that. And with time, I would say you feel with your hand before even you tilt to 30 degrees. With the feeling, many times you feel that you are in the right calyx, in the right place. When you pop the capsule, you feel it. It's very important for endourologists to when you manipulate, when I teach the resident, they look at the monitor and the x-ray. I tell him, what about your feeling? What do you feel in your hand? The feeling is very important. When you go with the needle, you feel there the capsule. This is the girotta. This is the capsule. This is the collecting system in my hand. Okay, if you feel this, and if you properly position your needle, you can do biplanar, monoplanar, bullseye technique. All are feasible. But I recommend you to master one. If you play around the three techniques, sometimes it's difficult unless you are very expert like Dr. Paul. Okay, but if you are a trainee or you are adopt one because they said a jack of all, master of none. Okay, so don't be jack of all. Adopt one way. I prefer the triangulation. Many people prefer other ways, and do it. And if you do it properly and repeatedly, you will have a good practice, and most of the time you will succeed. Thank you.
Thank you.
See,
Dr.
there is no difference, monopolar or biplanar. As soon as if you are doing in one particular plane, if you don't succeed, and by taking the guidance, putting in the second plane, then it becomes biplanar. My question to all my colleagues will be, how would you like to drive your car? With both eyes open or just with one eye? Even if you close your one eye and if you drive the car, you can drive it, but you will not be able to realize the actual distance between the car in front and your car. Please try it. Try it. When you are driving and suddenly you close your one eye, the car which is in front of you, you will not judge the exact distance. You will become shaky and suddenly open your second eye. So it is, if you are expert in one plane, you will succeed 90% if you are expert. 10% you will have to have the guidance of the second plane. You will have to turn 30 degrees to see what you are feeling, that you are at the right place. Are you really at right place or you are not at right place? That will be known by the second plane, and it becomes biplanar. So it is always better to remain open. Sometimes even with two planes, you will not be able to judge the distance, and you will need introduction of a third modality, ultrasound. Then only you will come to know that this is the depth of the anomalous kidney. So it is a blind procedure. Whatever guidance you are getting in one plane, two plane, or with the third modality, ultrasound, you must take it. So we should not be dogmatic. Yes, regarding technique, you should master one technique: bullseye, triangulation, or gradual descent. Gradual descent gives you the most lateral puncture, most bloodless field. Out of my 10,000 plus cases, not a single case of angioembolization, because I always prefer gradual descent technique, entering through the most lateral white line area, convex border of the kidney, and that gives you the least vascular injuries. So anyway, it is not that I am the only one who is getting such a good success. There are 100 others who are getting good success with their own techniques. But you should be open with all the three modalities, 1 plane, 2 plane, or with the ultrasound also.
Thank you, Dr. Pal. Thank you so much. That we can understand that you are with triangulation and not monoplanar. And we will remember this sentence. We have to drive with 2 eyes. Thank you, Dr. Pal. Actually, the time is over. It was interesting discussion. Thank you for all the speakers, all the guests of honor, and for our attendees, our colleagues from Yemen, Palestine, Iraq, Qatar. And I'm so sorry for that we cannot answer all the questions because of the time, but this activity is one of series of coming activities. It will be either around the PCNL or any subject of endurology. We have one poll. We want our attendees and panelists to respond to help us to select what is the coming, what they prefer, what's the coming webinar. There is one question, because we already asked this question about planning to change to Supine PCNL, and we will repeat the same question now after this webinar. Are you planning to change to Supine PCNL? The second question, are you planning to perform mini PCNL? And the last question about the title of the coming webinar, what do you suggest? Flexible URS tips, tricks, and updates, or advanced course in neurodynamic, or metabolic evaluation and medical management of stone disease? So the result for the poll, the 71% planning to change to Supine PCNL, and 94% planning to perform mini PCNL. And for the title of coming webinar, 49% and selected flexible URS tips, tricks, and updates. So we are respecting this choice, and we will prepare for this webinar, inshallah. Thank you everybody, and please have a good night.
Thank you.
Thank you so much for the organization and the panel, and Dr. Pal for joining us, giving us your experience and opinion. Thank you so much.
Thank you very much. It is 11:30 now in India. So good night. Good night to all of you. Thank you very much. It was very interesting. Thank you.
Thank you.
Good night.
Thank you very much.
Good night. Good night. Thank you.
for
Good
our
night.
Thank you دكتور حيدر.
دكتور حيدر thank you.
تصبح على خير. شكرا دكتور عمار.
شكرا
للجميع.
شكرا
للجميع.
شكرا جزيلا.
الله
شكرا
يسلمك.
جزيلا.
يا مرحبا. يلا السلام عليكم.
في امان الله.
دكتور حيدر ضروري يشارك معنا في النكست
ان شاء الله ان شاء الله ان شاء الله على الويبنر القادم ان شاء الله نشارك معكم باي شيء سواء كان محاضره او غيره.
دكتور حيدر انت عرفت الان عنوان النكست ويبينار، فان شاء الله تشارك معنا ان شاء الله.
ان شاء الله ان شاء الله ان شاء الله ان شاء الله.
شكرا لكم جميعا.
نبقى على تواصل ان شاء الله. مع السلامه.
ان شاء الله. السلام عليكم. مع السلامه.